Dr. Bacchus, Malcolm Bacchus, renowned Reno neurologist, buddy of mine for many, many years. We saw a patient 2 weeks ago. He's a 55-year-old City of Reno cop. And he was shopping at Meadowood Mall, and he'd been in there about an hour, and he came out, and for the life of him, he couldn't remember where he parked his truck. And he came in, he had a history of Alzheimer's in his family. And he came in and he wanted to know how he could find out more about this and if in fact he was experiencing some of the earliest symptoms of this dreaded disease. And so I bet that's a question or a situation that you've been involved in before. So we were wondering, what do you do in the earliest phases of your suspicion of this disease? What kind of testing are you doing? Are you doing imaging? What's your approach to?
One a day I see of that situation, and that's an excellent lead into what the community neurologist tends to see frequently. So, using this fella as an example, and by the way, I appreciate Gary and Tara's comments on the vascular biology of Alzheimer's. They were excellent. So, but we will. Let me just give a little framework of what dementia and how the neurologist approaches dementia. They're not demented, or they're demented. These two sort of constructs, the American Academy of Neurology guidelines started out with and collect data in that, not demented, demented. A few years later, late 1999, 2000, this middle part started to get filled with an entity that's now become what's called mild cognitive impairment, or MCI. And lots of things live in that middle part, including the most common dementia in the United States, Alzheimer's dementia, and the second most common dementia, so-called vascular dementia. So let me just say on mild cognitive impairment, roughly what we're talking about is a patient comes in with a memory complaint. I can objectify a little bit of that, yet they have no other impairments in the other domains of cognition that we sort of check for the diagnosis of Alzheimer's. So it's where the reason I'm bringing it up is most of the people we see will wind up in that. A lot of people we see will have no dementia, but frankly, most of the people we see now, we are starting to put that down as an entity, and only for, not just for academic sake, but when a treatment, and by the way, no known cause as of this second for Alzheimer's disease, and no known treatment to disease modify it. So, however, once a disease-modifying treatment comes, and we're probably closer than I thought, this is obviously where the selection process might begin, is in early mild cognitive impairment. So we starting to put that down a little bit more on our charts. So, and by the way, if there's 5 million Alzheimer's patients now, and more than 5 million people in this MCI category, think about that. And the baby boomers now in this, another risk, by the way, is age. And they're coming into this high-risk age at a huge number that we've never seen before. They're talking, 15, maybe 20 million in the next, varies from next 10 to 30 years. The system will not be able to handle that as the line forms to want the treatment, and who's going to be picked. There's not enough money to do it, and a lot of the chief investigators around the country for Alzheimer's, they're saying, I don't know what we're going to do, because it's a massive number of people coming. So, with that background, this gentleman will come in either alone, and we call that self-reported cognitive complaints, or usually the case, and we hope that an informant, as they're called, usually the spouse, will come in with them. And I'll have them come in, and I try to sit down and be as relaxed as possible and do not challenge the patient with anything. I want to carry on the most mundane conversation I can. And no overt cognitive test out of the get-go when they walk in the door. And I will kindly ask the spouse, let's say in this case it'll be a wife, I will ask her for some help later on in the interview. So I want to just talk to this man very casually, make him feel comfortable. How's your day going? How was your trip here today? He may have a San Francisco Giants cap on, and I might say, when's the last Giant game you saw? And with this conversation like that, I can tell almost, usually you can come close to making the diagnosis right there. As you watch his attentiveness level, as you watch his responses to your questions, how rapid or not so rapid, his pauses for word finding, and how many of them are there. Is he always looking over to his wife for help and wondering what's going on here? And sometimes I'll even ask them, do you know what you're doing here? But very, very mundane, make him feel a little bit at ease, and 3-4 minutes. I've got a lot of data. Because later on in the interview, I will support that with talking to the wife or informant about when his last Giant game was. And she may tell me, Doctor, we went to that game last night. She may tell me, he thought we had an uneventful drive here, and we got a flat tire. We're driving from Susanville, California, and I thought we'd never make the appointment, and I was almost going to cancel. We had AAA come. So I find out in a 30-minute to 45-minute, maybe office visit, all I need to find out. So, and if I want to pull from one of my multiple files in the office from 4 or 5 different quizzes or questionnaires we give in 10 minutes for mental status examinations, I can verify a little bit about what we're talking about with him not knowing the Giant game yesterday. He can't acquire a new memory. He can't remember recent things. He can't remember recent events or conversations. If it's a close call, I will just maybe grab one of my sheets at the end of the interview with him and start asking him things. But I might, in one of these little questionnaires, ask him, I'll give you 5 words. Repeat them back to me. I'll wait till he does it satisfactorily. If he can't make the 5, we'll go to 4. And I give him another chance to say it in order, and I'll say, I'll ask you in 5 minutes what those are. Would you please remember them? And that's all I need to know, because most of the people I see, they can't give me 2 or 1 back. Okay, so it's between the wife, between this guy, and between that little test in the office, I've got the emblematic demand and emblematic requirement for the diagnosis of Alzheimer's dementia. Dementia meaning a consistent loss of cognition from a previously higher level, the dementia syndrome, if you want to call it. The number one in all the criteria that are used, whether it's the National Institute of Stroke, whether it's the American Academy of Neurology, whether it's the DSM-4, the Psychiatric Diagnostic and Statistical Manual for Mental Disorders, need this one requirement of no new memory acquisition or impaired memory acquisition to even go any further to establish other criteria. And that's really, I'm almost there after the initial conversation. The other thing, so I have to pick from 2 or 3 different other cognitive domains to sort of make the diagnosis here at this office visit. I know about his language already. I know he pauses a lot. I know he's using circumlocution. I know he can't. He'll use 6 or 7 words to try to describe pen to me. If I again, I might ask the spouse, what's he like at home? engage in conversation. He said, "Doctor, he used to talk a lot, but now he's not saying much at all. And when he tries to say something, he just stumbles on a word, and he keeps trying and trying, and he gets so frustrated, he walks out of the room." So I got that. And again, any question, I will say, ask him again when I start the testing, which is, doesn't take much. Name as many animals as you can in 60 seconds. Or repeat a phrase to me. I only know that John is the one to see today, for example. You gather pretty much all the data you need for a clinical diagnosis there. So language is early, along with memory acquisition in Alzheimer's disease. And it's not sequenced strictly by any means. But if you want to lump a little bit what comes early, it's the acquisition of new memory and language dysfunction. Language is a criteria that all these guidelines use, and they say that with acquisition of new memory impaired as a mandatory criteria, that only one more is needed out of 3 or 4 more options depending on the criteria. I've already got my option, language. And that sort of, is get me to the equation. We also explore a little bit visual spatial, the visual spatial, this breakdown in the Alzheimer's patient of visual processing, this motion detection gets impaired. The placement, they'll put objects in different places in the household, that not because they're forgetful, because we all misplace keys. We all misplace the car we park sometimes. But when you start putting things in the freezer, the keys in the freezer, something's not quite right, and the wife will corroborate with, "Doctor, he's got his socks and shoes all over the place. He used to be so tidy." A week ago, I had a patient come with his wife, and told me, because I always ask him about driving. He said, we were in our car, my wife was in the passenger seat, and we were trying to get into the left lane to make a left-hand turn. There was a car on the left side already, a little ahead of us, and I put my signal on, and my wife was there, was watching, and I made my move to get behind this car into the left turn lane, and I ran right into his rear fender. I can see fine, 20/20 vision. And it's this motion, visual spatial kind of distortion. The figure ground discrimination is off. How do you tell the difference between someone walking and the ground itself? That starts to go on one. And this Alzheimer's age group, and the higher the age, 55, it doesn't matter the age. It can happen at any age, although the younger ones are usually the rare, fortunately, 4 or 5% who have the familial autosomal dominant. One parent has a gene, you're going to get Alzheimer's 100% with certitude. All you need is one. So it can happen at that age very easily. But we'll tied in with the visual spatial category as a criteria is another thing called apraxia, and I'll move through this a little quicker here. But apraxia, where they forget skilled movements. My husband, doctor, went into the garage frequently to use his tools, and I've seen him in there lately, and he's got a screwdriver in his hand, and he keeps trying to put it in the right, and turn the screwdriver, and he just can't get it done, and he gets discouraged and comes back in. And I will easily check on that with, show me how you would, if you had a pair of keys in your hand, show me how you turn the car on. Or I might give them a cup of water. I might give them a cup, empty cup, and ask them, show me how you'd use this. And they will just look at it sometimes and say, well, I think this is a cup, but they don't know. They've forgotten the act, the execution of the skill Interestingly enough, sometimes you put water in there and ask them to do that, and they take it and go just like this. It's sort of a triggered response. But this kind of thing we're talking about, you'll give someone a pair of scissors and a piece of paper and say, cut this, and they don't even know how to go about connecting the paper. So this dyspraxia in this visual spatial category, this third criteria, that's probably the next to see. These are the three most common arenas you'll see in Alzheimer's if you take an average patient coming in with even early dementia. I'll just mention a fourth criteria is executive function, and the boss of the ego and the brain of what I'm going to do, how I'm going to do it, how I strategize, can I multitask? That's a little tough to pick out, especially if there's language deficits and other things in front of you. But that tends to go as well. So again, recent memory acquisition, you in trouble. You need that for the one criteria, and any of these other things will do it. I will usually then, at the end of the evaluation, I will have one of my staff take one of the several questionnaires I have. The MMSE, or Mini Mental Status Exam, is universally done, because a 21 out of 30 translates in Arkansas like it does in South Dakota, like it does in Nevada. It's probably the weakest of the bunch, but that's okay for, information exchange and get your bearings a little bit quickly. If there's someone with a mild deficit, maybe that mild cognitive impairment group, it comes up short a little bit, especially with visuospatial. So sometimes I'll have them do the Montreal Cognitive Assessment Test, which has a lot more visuospatial challenges in it. Draw a clock for me. If you want to see how executive function is challenged and how visuospatial is challenged, that takes a lot, and I'll say draw a clock with a time of 2:45 on it. So that's a very good test for both executive function and for visuospatial. I'll say draw a cube, and so we get data that way, pick and choose depending on who I'm going to, who's I don't need to do that with, or who I do need to do that with. I will then do a brief neurological exam. Most of the time it's normal. Whether we do, if they haven't been already done, and often the primary care physicians have seen the patient, and often they've already gotten, let's say, an MRI scan, but I usually have to do a CAT scan, or preferably an MRI scan, and make sure you're not getting fooled by something treatable. That's unfortunately, very low percentage of manipulable disorders in the workup. But things like occult hydrocephalus with enlarged ventricles, the demonstration of the second most common dementia there is, vascular dementia. And really what we're talking about is small blood vessels. This large blood vessel concept is slowly going by the wayside as far as being a dementia producer, but multiple small blood vessels. We know risk factors for that with hypertension, maybe insulin resistance. And what we don't know is that hypertension, for example, in people without Alzheimer's can show atrophy in the hippocampus, these medial portions of the temporal lobe that are affected early in Alzheimer's. Hypertension alone can do that, believe it or not. Alzheimer's can do that, believe it or not. That's where it tends to start. The combination of someone who's got vascular dementia, and it's frequent and it's hard to sort out, and but the combination, what studies have been done in always limited numbers of people, show those people with both show way more than either alone. So the issue comes is hypertension contributory to actually Alzheimer's disease itself, the disorder, this idiopathic cause unknown disorder. Or is it strictly causing damaged brain cells and adding to the lack of reserve to work with, so Alzheimer's can gang up on it, kind of a thing? So that's sort of where that is.